Thank you, Jeremy. Hope everyone can hear me well. So I was given the topic of listeriosis or human listeriosis to present today. Really a fascinating organism, fascinating pathogenesis, and unfortunately devastating results to many patients. So we'll get to why it's called the ultimate Trojan horse as we discuss the pathogenesis. So listeriosis, we know it's a foodborne infection. It's considerably rare. It can also be zoonotic in origin. The spectrum of the disease will range from self-limiting gastroenteritis to really serious infections of the central nervous system and or bacteremia, predominantly in those with impaired cellular immunity. Pregnant falls category to some degree. It has one of the highest mortality rates of all foodborne infections. The mortality rate of listeriosis related to foodborne outbreaks is between 15 and 20%. Again, that's all the milder cases of simple gastroenteritis, but we'll come to that. It was first identified in 1926 during a laboratory outbreak in rabbits. So again, it's a zoonotic organism. Really can affect a host of different mammals and even some birds. It was first clearly documented as a case in humans in 1929, and this was a case of gram-positive bacilli causing a meningitis in a patient. The role as a pathogen was not clearly realized until there was an epidemic of listeriosis in newborns that occurred in Germany all the way back in 1949. And this was in fact granulomatous infantiseptica, which is one of the neonatal variants or maternal fetal forms of the disease in around 85 newborns and or stillbirths. The first clear foodborne outbreak considerably later in Nova Scotia in Canada, and this was only in 1983, clarifying the primary route of infection being via food, but the majority of cases are actually sporadic. So in terms of the microbiology, it was initially named Bacterium monocytogenes, and that's when they discovered it in rabbits, and that was because it induced a monocytosis in rabbits, something we don't really see that much in humans. It's ubiquitous in the environment. Again, if you look hard enough, you'll find it in ground, soil, decaying vegetation. And as such, it does colonize around 4% of humans' gastrointestinal tract and a much higher proportion of ruminants who are sitting eating that ground, soil, and decaying vegetation. It's a small gram-positive bacillus. It's flagellated, has bipolar flagellae. In terms of the microbiology, it's catalase positive, oxidase negative, weakly beta hemolytic. Again, that can be variable, and what's called the CAMP test I'll show you is positive. It exhibits this interesting tumbling motility, which often gets the microbiologist very excited when we see it, and it is facultatively anaerobic. It survives in a very wide temperature range, 1 to 45 degrees. It hydrolyzes bile salts, so on a plate it'll be bile esculin positive, and it tolerates a pretty low pH, can grow in the presence of fairly high salt concentrations, and it's these four that really promote food. It can live in a vacuum pack, live in your fridge, it can survive in your gut. Those are the things that lead to food. And then it has this unique intracellular life cycle, which allows it to really be immune evasive. Some pretty pictures, just to clarify, these are the gram-positive rods that one might see. This is on a CSF, although in CSF it's not usually this profound and now. The bipolar flagellation has flagellae on both sides. This is the positive CAMP test. So you can see on the Listeria is actually what you see on the left and the right, and growing in small little colonies with minimal hemolysis around them. But when you grow it near a streak of an organism that is overtly beta hemolytic, usually Staph aureus, you see accentuated hemolysis by the Listeria organism. There's a number of organisms that are CAMP test positive, and this is used in the laboratory to identify the organism. The tumbling motility that displays, it's again very interesting to see. I hope that the video is playing, but you can see these guys look like they're having a real party, and you literally see them in a suspended drop bouncing around on the slide. Okay, so a little bit about the epidemiology, so we know when, where it occurs, when we should suspect it. So it has an incidence of around 0.1 to 11 million cases. So 1 to 11.1 to 11 cases per million per year, apologies. The peak incidence actually occurs in the summer months. Again, that sort of correlates with many other foodborne illnesses. Incidence is highest in low socioeconomic settings and at the extremes of age. Pregnancy-associated listeriosis in many studies has been shown to have a high incidence in ethnic minorities, which again probably reflects sort of food consumption habits. The case fatality rate is 15 to 20%, and that's predominantly the invasive disease. And again, we probably miss most of the gastroenteritis. And the global mortality, there was a study done in 2014 looking and modeling somewhat to gauge the global mortality, but in 2010 it was estimated to be around 50,000 in a year. So again, significant. In terms of the organism itself, there's a number of serovars and serotypes, and these are based on the combination of the two major antigens, the O antigen and the H antigen. There's two distinct phylogenetic lineages with 13 serovars that have been described, but of these, it's the 1,2b, the 1,2a, and the 4b that are actually responsible for the vast majority of infections. Certain subtypes, for example, 4b, are more virulent and they're implicated in more immunocompetent type patients. And interestingly, if you look for certain clonal complexes and serotypes, they actually can be associated with particular foods. So certain serotypes will grow better in a certain foodstuff than others. The utility here, obviously, beyond understanding the organism itself, that the serovars, the serotypes, and phylogenetics can be used to confirm outbreaks in a suspected outbreak. In terms of risk factors, this is a table from the Mona Lisa study, which was the largest cohort of Listeria cases done in France. So just a couple of things, sorry, apologies, the slides all over the place, that it's a disease of the elderly, okay, most commonly. You'll see that the median age was around 73 in bacteremia, slightly younger in neurolisteriosis, 67. But more importantly, that most of these patients have some degree of comorbid illness. The median number of comorbidities in bacteremia was 3, and in neurolisteriosis was also 3. And many of these comorbidities are in fact thought to be immunosuppressive. So again, it's fairly broad. I'll discuss what's considered an immunosuppressive comorbidity on the next slide. But the vast majority of these patients, taking into account the immunosuppressive conditions, 97% of those with bacteremia in this study and 86% of those with the neurological forms of the disease had at least one immunosuppressive comorbidity. So what are these comorbidities? Well, looking in, again, the Mona Lisa trial, they looked at a couple of non-immunosuppressive comorbidities. Now, these really probably just reflect the age groups we're dealing with. So chronic respiratory diseases, heart diseases, or cardiopathies, high blood pressure, renal insufficiency. Chronic liver disease, perhaps less so, and it certainly is an immunocompromising condition, and they actually consider it on both groups. Interestingly, recent major weight loss is also considered a risk factor. If you look, 27% of patients who had bacteremia had recent major weight loss. Now, that may just represent, again, chronic illness or as yet undefined chronic illness. If you look at the immunosuppressive comorbidities, so again, diabetes mellitus is a real big player. Solid organ tumors, interestingly, more so than hematological malignancies. Patients over the age of 70 consider the age itself to be immunosuppressive, and any corticosteroid or immunosuppressive therapy, again, 32% of those with bacteremia and 28% of those with neurological disease were on some form of immunosuppressive therapy at the time of infection. It's not technically an immunosuppressive condition, but I just wanted to demonstrate that antacid therapy, again, may be reflective of the age group in which we're sort of looking at with listeriosis of the age of 50. A lot of people are on PPIs, but a large portion of these patients are on antacid, and there is certainly a physiological framework why that could result in infection. Some age risk pregnancy, although these patients tend to get a bacteremia that is often transient without the corticoids and other immunosuppressive therapies, solid organ tumors, neoplastic diseases, and that's both hematological and solid tumors, HIV, there was previously some debate about that, but I think our outbreak solidified that, liver disease, kidney disease, iron overload states, ethanol use, and diabetes. Foods that are associated with Listeria contamination. Now, this is a table from Up to Date, and to be honest, it's actually probably too short. If you were to actually pile up the list of foods that have been implicated in varying outbreaks, the list is a lot bigger. But some of the common high-risk foods, improperly reheated, essentially processed meats, so cold cuts, luncheon meats, hot dogs, all the good things in life, I suppose, and other forms of poultry, if they're not heated up to at least 74 degrees. Raw milk, which again is the classical risk factor. Soft cheeses, again made with unpasteurized or raw milk. Refrigerated seafood, store-made salads, again varyingly implicated, and probably has to do with the replication while it's refrigerated. Refrigerated pate, meat spreads, and unwashed raw fruits and vegetables. And we'll discuss an interesting cantaloupe or melon outbreak at some point. And raw lice. And this again continues to grow based on outbreaks. So yeah, the mortality, again, as we discussed, carries a high mortality with bacteremia. If you look at the red line on the left-hand side, you can see bacteremia versus meningitis versus pregnancy-associated. Bacteremia carries the highest mortality. And in fact, even in the setting of patients with neurological disease, the presence of concurrent bacteremia referred to much higher mortality. So essentially, why is it such a difficult bug? Well, because it's a well-adapted organism. It has multiple hosts and it's haplolytic. It doesn't need a host at all, and it's immune evasive. Okay, and it survives again at low temperatures in these acidic environments, in the presence of high salt concentrations that can infect multiple different organisms and animals, and it has this interesting ability, which we'll discuss in detail, of invading placental tissue, blood-brain barrier, and how it gets into us in the first place via the intestine. So how does it do this? Well, there's a whole number of virulence factors that allow cellular invasion. So looking in the middle, the well-known ones are these internalins, internalin A and B, and essentially they facilitate adherence of the organism with specific cell types, specific receptors on specific cell type walls, and that facilitates internalization of the organism. And again, many of these have been defined for the different cell types that it can invade, in addition to which there's a number of other virulence factors. On the far right, you see what's called Listeria, which again, we'll discuss its role in pathogenesis and certain other autolysins. So there are three stages of the infection. So the starting point, the contaminated food that gets into our gut. We then have subclinical translocates, often by the portal vein, and you get a subclinical focus of hepatosplenitis, subclinical focus within the liver and or spleen, and that's where the immune response, initially a mild innate response and predominantly the adaptive immune response, takes care of it. Failure of that response will lead to dissemination via the bloodstream, and from there it can disseminate either, it can be a primary bacteremia, become a meningoencephalitis, or placentitis, invade the placenta. So survival within the GIT, as we've mentioned, is facilitated by its ability to survive at relatively low pHs. It then gets into the small bowel and it hydrolyzes the bile acids, which are often antibacterial in nature. And so that allows it to continue to propagate within the bowel. In a little bit more detail, it has a couple of other things that allow for its virulence. So firstly, in the intestinal lumen, it encounters many other bacteria that will obviously inhibit growth, propagation, but it secretes something called Listeria S, which actually inhibits much of the gut microbiota. So that's the first step of survival and intestinal lumen. Then it needs to invade. So it invades via the villi within the small intestine, and there's three cells in the Peyer's patches. The other is at points of extrusion of apoptotic cells of the enterocytes themselves, and most commonly it's thought to enter via the goblet cell. There's receptors that facilitate this. So in detail, again, I'm going to focus on the panel on the right. The left is essentially the same thing with very pretty electron micro that show each of these processes, and fascinating. So you have intracellular invasion, which is mediated via internalin A and B. It's endocytosed, remains within the cell wall with the cell itself in the cytoplasm within a vacuole. It then dissolves that vacuole via Listeria combined with fibers A and B, and that allows it to exist freely within the cytoplasm. It then actually hijacks your actin via this actin A protein. It essentially hijacks actin and can propel itself around your cell like a rocket. And eventually it will hit certain walls, and if it hits them with enough force, it actually facilitates entry from one intracyte into the next, or from one enterocyte into a macrophage. So again, just to illustrate this, how it really bounces around this actin assembly inducing protein, or actin A. They're called actin rockets, and they very much look like actin. I hope everyone can see this. Turn off the audio. So it literally bounces around the cell, and again, in this, there's no adjacent cell, so it doesn't leave the cell. This is in culture. But it can bounce around the cell, hijacking the actin assembly, makes these little sort of rockets which facilitate movement intracellularly. I'm just going to skip ahead, because here they've used fluorescence to demonstrate, again, these so-called common tails of the organism. It's really quite fascinating. And then a bit later, they've modeled how it actually uses them to propel itself around the cell. Okay, so the next step is modulation, is further modulation of the host cell themselves. So it also, the Listeria lysine that we discussed also results in pore formation on the cell wall, which allows for this influx of calcium and potassium. What that leads to is a degree of mitochondrial fission. So it's a reversible process. Our mitochondria do naturally sort of divide and then come back together, but it in a sense paralyzes the cell. To some degree, it paralyzes some of the metabolic components of the cell, which allows it to continue its replication. It will eventually leave the cell, often without necessarily destroying it, and this process of mitochondrial fission reverses back and the mitochondria continue to function. Another interesting component of the pathogenesis is actually that it can act within the nucleus itself. It binds to histones and affects chromatin remodeling, and it actually affects the cell's ability to call for help. Essentially, it affects the cellular signaling and decreases the release of certain cytokines that otherwise would induce an immune response. So then it makes its way, the little macrophage makes its way back into the bloodstream or via the lymph nodes, and it eventually gets to the liver and or spleen. Within the liver, again, this is a mouse model. I'm not going to go through the pathogenesis in detail here, but what they've done is they've looked in mice models, obviously looking at varying stages of infection and then analyzing the mouse itself in autopsy. 60% of the bacteria actually cleared within about 10 minutes. They're cleared by the liver. They take up residence within the liver, and then they continue to divide. They can exist within phagocytotic cells, and they can exist within the hepatocytes. They interestingly don't induce an overt hepatitis, even though there is some degree of hepatocyte damage, usually mediated by the innate immune response against infected hepatocytes. And after around 7 days on average, a lot of this has been mocked up by the innate response, but the remainder requires an adaptive or cellular response to actually clear. And so in patients who fail to clear via that cellular immune response, those are the ones who will go on to become bacteremic. Then obviously you said it can be a primary bacteremia, or it can make its way to two specific sanctuary sites. So the first one I'm going to discuss is the placenta. So again, hijacks that macrophage, that's the Trojan horse, makes its way through the bloodstream and gets to the placenta. Via the spiral artery, it enters the uterine deciduum, and it can actually invade certain of the trophoblasts. Now that invasion is in fact mediated by the same two receptors, internalin A and B, and E-cadherin and c-Met, that exist on intestinal cells. So it's that cellular homology that actually allows for tropism towards placental tissue. Once it gets into the placenta and gets into the fetal circulation, it's a sanctuary site. It's protected from the host immune response further. So that's why in maternal infections, the bacteremia from the maternal side will be cleared, but it will potentially wreak havoc on the fetus. How does it get into the central nervous system? Here, there's a lot more question marks. So the prevailing theories are twofold, that via choroid plexus invasion, again, via internalin A and B, there's thought to be an internalin F that is also involved in this process. And it also essentially can invade via the choroid plexus cells, make its way across the membrane and into the CSF. The other thought, and again, this has been demonstrated in animal models, is that it can enter into the endothelium via phagocytes, which are infected. And then once they are within the central nervous system, the organism can make its way into other cells. The third mechanism I'll discuss in detail when we talk about rhomboencephalitis, and this is thought to be direct infection via the trigeminal nerve, in fact. So it doesn't have to become bacteremic or invasive per se to cause infection. So what are the clinical syndromes that it causes? Well, I'm going to discuss the primary 5 of them and just briefly mention other sites of infection. So firstly, a febrile gastroenteritis. So again, you can see the stool chart on the right, the Bristol stool chart adapted, type 6 and 7, diarrheal stool. So this presents with acute watery diarrhea, very rare to have bloody stool, and often a low-grade fever. It requires a large inoculum of Listeria monocytogenes organisms, apologize, I didn't italicize that, to cause febrile gastroenteritis. But the large inoculum doesn't matter as much. If you think about things like Shigella, it needs about 10 to 100 organisms to cause infection. Here you need 10 to 100 million, but it can survive at refrigerated temperatures. So if you leave something for long enough, the 10 to 100 Listeria organisms will become 10 to 100 million because replication continues in settings where often foodborne pathogens do not continue to replicate. The mean incubation for febrile enteritis is 24 hours, can be between 6 and 10 days, and usually lasts for around 2 days, self-limiting in the majority of cases, and it's likely missed in most because we don't routinely test for this pathogen within patients with gastroenteritis. It should always be considered in the setting of a foodborne outbreak, so there one should always test for it, and I know how IPC lab certainly does when there's suspected foodborne outbreaks. And in invasive listeriosis, around 15 to 22% actually report concurrent gastrointestinal symptoms. So it's not an uncommon manifestation of bacteremia or neurolisteriosis. There is a big question of, in the absence of a bacteremia, to treat or not to treat, and we will discuss that once we talk about treatment itself. So now bacteremia, this is the most common form of invasive listeria. It can lead to localized infections, most commonly neurolisteriosis, and less commonly endocarditis, things like septic arthritis. Most cases, as we mentioned, are in fact sporadic in patients with predisposing conditions, and the majority, in fact 97%, have some form of immunocompromising condition or are over the age of 65. As I mentioned, a third of patients with neurolisteria, with bacteremia, will have a malignancy, and it's interestingly solid tumors more than hematological. The mean time to presentation from symptom onset is 2 to 6 days, but the incubation period can last anywhere from 7 to 90 days, a mean of 11, and the majority are within 1 month. But that makes, where you have recurrent invasive disease in the setting of an outbreak, can make it quite difficult to track back to the source of the outbreak. I certainly can't remember what I ate a week ago, let alone 3 months ago on a given day. So the manifestations present in a continuum, ranging from very non-specific symptoms such as fever, again in the majority, tachycardia, diarrhea, chills, myalgia, all the way to septic shock, multi-organ failure, and or death. In terms of markers of infection, again, it induces a CRP response. The mean is around 115, although there are reported cases of normal CRP, less than 3%. Procalcitonin is elevated, but less so, as we do often see in intracellular organisms. 84% will have a lymphopenia, only 16% as compared to the rabbits will have a monocytosis, 14% will have a monocytopenia, and it's actually one of the adverse prognosticators, so something to look at. Morbidity, mortality, very high, around 21% require ICU, up to 10% usually in the setting of multi-organ dysfunction require ventilation, and the mortality can range anywhere from 21 to 46%. Right, on to neurolisteriosis, really one of the fascinating types. Again, listeria has this unique tropism for brain tissue, and we've discussed how it sort of gets there. The majority are in fact a meningoencephalitis. It's not it's a true meningitis is in fact slightly less common than invasion of the parenchyma of the brain itself. The mechanism of invasion, as we mentioned, is not fully established, although there's the existent 2 to 3 theories, some of which have been demonstrated in animal models. And it's the second most common form of invasive listeriosis. The incidence is decreasing, probably related to food safety, but it remains in the top 5 causes of a central nervous system infection in the developed, probably more common than the common CNS pathogen worldwide. And if you look in a subset of patients with diabetes, alcoholism, or immunosuppressive therapy, it's the second most common cause of meningitis, again, according to one paper I read. The majority have comorbidities, again, 84% with immunosuppressive conditions, but there is a subset of patients that have no documented immunosuppression, and this is around 14 to 37%. These patients will more commonly have either an isolated meningitis or this unique rhomboencephalitis that Listeria can cause. In terms of comparison to bacteremia, the patients tend to be slightly younger. The majority will have comorbidities. A subset of patients with no comorbid immunosuppression is mentioned, and on the right, the panel to demonstrate on the left is those with predisposing factors. On the right, the white line is those with no predisposing factors, and obviously the white line sort of grows as one gets older, because the age itself probably is somewhat immunosuppressive, or the incidence of malignancy and things like that. Again, here the incubation is a bit shorter, and the median is around 10 days. Patients tend to present a bit later, 3 to 4 days after symptom onset. And we can have a more subacute or indolent presentation, cases where the onset of symptoms is up to 2 weeks. So in our setting, it does make you think of tuberculosis, for example. The majority of patients will have a fever, fewer will have an altered mental status, and even fewer, in fact, have a headache. Up to 2/3 will have no meningism. So as mentioned, it may be more of an encephalitis than a true meningitis. What about mortality? So factors associated with mortality: neurological disease, older age, female gender, malignancy, weight loss, monocytopenia, again as mentioned, less than 200 cells per microliter. The concurrent presence of a bacteremia, as I showed you from the Mona Lisa study, where it's an independent predictor of mortality, and interestingly, dexamethasone administration, which is something to bear in mind in all patients with bacterial meningitis or suspected bacterial meningitis. Many of them will be put on dexamethasone, a separate discussion as to the benefits in pneumococcal disease. But if, for example, pneumococcal meningitis has been ruled out and Listeria is ruled in, certainly the dexamethasone should be. There's several variants of the disease. Some exist on the spectrum. So as mentioned, only around 13% will have a pure meningitis. The majority will have a meningoencephalitis, and that often will progress to form, a cerebritis, abscess, and that's again along a spectrum. Rhomboencephalitis, probably a unique and different pathogenesis, and I'll discuss it in detail in the next 2 slides. So this is just some imaging on the left. The bottom, you can see meningeal enhancement with sort of a global cerebritis. It's really lighting up. The top left, you can see an MRI with focal cerebritis. In the middle panel, some MRI demonstrating abscess formation, not common with Listeria, but it does occur. And on the far right, CT and MRI images of rhomboencephalitis, this unique form of the disease itself. So in terms of CSF findings, interestingly, only 1/3 of patients will be positive on a Gram stain. The majority, however, of conventional neurolisteriosis and meningitis and meningoencephalitis will be culture positive. The patients generally have a high protein. The median was around 2.1 grams per liter. They only have a slightly low glucose. The median ratio is in fact 0.31, but you can see there's a fair spectrum of patients on the far right that in fact have essentially a normal CSF to glucose ratio. So glucose is not a reliable indicator to exclude it. And perhaps in the setting of what looks like a bacterial meningitis, if it's within the normal range or close to the normal range, may make you think of listeriosis. The pleocytosis is variable. Again, the cell number can be anything really from 0 to several thousand. But what's fascinating is that the spectrum of polymorphs versus lymphocytes really can be anything. So this is a distribution of polymorphs that can range from 0% polymorphs to 100% polymorphs. So it can be a pure lymphocytic type meningitis in not a small proportion of patients. About rhomboencephalitis, and to start that off about a zoonotic condition, this is a strange story that hit the news a while back, and it was actually on several news outlets. Interestingly, every time I searched, there was this weird video out of China of all these sheep just trotting around in circles for essentially 2 weeks. In circles, and there was all these conspiracy theories, as there always are with these strange videos. One of them was that they had what's called circling disease. They did not have circling disease. It was hard to find a video of true circling disease, but the animals are more cerebellar looking, but they do tend to walk around in very small concentric circles. Now, circling disease is a disease of ruminants caused by Listeria monocytogenes. It's an asymmetric infection of the brainstem. The pathogenesis is via Listeria monocytogenes, which enters via the trigeminal nerve, and the clinical signs in the animal will vary from a degree of lassitude and depression, not depression mentally, but lassitude, ipsilateral weakness, so long tract signs, trigeminal and facial nerve paralysis, and often affecting the vestibulocochlear, the red nuclei, with circling, with sort of almost cerebellar, they fall into one side and walk around in circles. So that brings us to human rhomboencephalitis. So it's a unique and fairly rare form of neurolisteriosis. Much younger patient cohorts. There are a few papers looking exclusively at this form of the disease. These patients tend to be immunocompetent. The majority, in fact, in one study had no immunocompromising illness. Only 1 in 5 had any comorbidity, so a much healthier cohort of patients. And the hallmark is evolution of progressive brainstem dysfunction over days, from a mental state change, cranial nerve dysfunction, cerebellar signs, and long tract signs. And this is from one of the papers looking at around 62 cases of this through the literature. And at initial evaluation, looking at the signs that were present and how they evolve. So one of the hallmarks is actually an evolution, and these patients can present very mild neurological deficits and progress to fairly severe neurological deficits. The CSF profile is slightly different. What's interesting is that it may initially be normal and subsequently evolves to be similar to those seen in other forms of neurolisteriosis, and that's probably to do with the portal of entry. So CSF cultures can be negative again initially in 60 to 70%. The yield is increased with repeat CSF. The progression is thought to represent this unique mode of infection similar to animals, where the organism invades via the oral mucosa, via the trigeminal nerve distribution, and makes its way directly into the brainstem. From there, it may spread to the CSF, and that's why perhaps you have the spectrum of normal CSF and negative culture, and subsequently becoming positive or inflammatory. Is undefined, but there's probably a unique predisposition that's thought to be related to a unique receptor on some patients that allows homology between this illness and that of circling disease in animals or humans. It carries a high mortality with appropriate treatment. So with penicillin or immunopenicillin, 24% of patients will die. And in the small cohort, those patients who were diagnosed post-mortem all died. It was those who didn't receive any effective therapy. The majority were left with neurological sequelae. So in the remaining 75%, I think it was around 70 to 80% of those patients had permanent neurological deficits. So really a catastrophic illness, and often in textbooks, sort of always links with listeria, but it's actually a fairly rare manifestation of listeriosis and probably separate to our conventional understanding of neurolisteriosis. This is the last slide on neurolisteriosis, but just something to do with long-term mortality in these patients. There was an interesting cohort from Denmark, which looked specifically at long-term mortality. And these patients over 5 years, compared to a control, had much higher 5-year mortality. After 5 years, it set us back to baseline. But more fascinating was in this cohort, they found that they had double the cumulative incidence of a malignant diagnosis. All solid tumors, none of them were hematological. For over a 5-year period, these patients would tend to, or were much more likely, twice as likely as controls at least, to develop a solid tumor. And in fact, the outcome of this paper, they suggest that in patients who have listeria, especially in the absence of clear-cut risk factors, or where age was the only risk factor, that you should aggressively and actively screen them and monitor them for the development of malignancy. And perhaps the working theory is that they had an undiagnosed malignancy in its early stages at the time of the infection. Moving on to listeriosis in pregnancy. So again, maternal acquisition, foodborne. This results in a bacteremia due to a relatively suppressed cellular immunity. So they have a 16 to 18% increased risk of a transient bacteremia compared to a non-pregnant female. There's a very low risk to the mother for central nervous system disease, and essentially absent mortality in many studies in the absence of another risk factor. So the concern is more for the fetus than the mother. The peak incidence is in the 3rd trimester, which is actually the peak of relative immunosuppression, but the fetal outcomes worsen depending on if you're infected early in pregnancy versus late in pregnancy. From a maternal perspective, it presents as a mild flu-like illness, often just with myalgia, arthralgia, and fever, and up to 30% can be asymptomatic. So where there's fetal listeriosis, early fetal listeriosis, the mother certainly had an infection and there were no clear-cut symptoms. Untreated, it's probably self-limiting. Again, anyone who proves a bacteremia in the patient will very rarely choose to not treat them. But in retrospective cohorts like the Mona Lisa cohort from France, there were cases that were found to be retrospectively diagnosed and had not received treatment, and it was 10% received no antibiotics, and it's obviously was self-limiting. The fever in the mother can persist if she develops an overt chorioamnionitis, at least until source control, so to speak, the fetus is delivered and the amniotic fluid is expelled. Vertical transmission is common, so 20% of patients who develop Listerial bacteremia will develop a stillbirth or spontaneous abortion. 68% of live infants will develop listeriosis, which can be divided into early or late, and I'll discuss that in a little bit. Early treatment is thought to improve fetal outcomes, generally advocated empirically if you have a febrile patient mother with a presumptive exposure, even in the absence of proving it. And prevention, obviously, avoidance of high-risk foods in pregnancy is ever-growing list. So from mom to child, the neonatal infection thankfully has a decreasing incidence in the developed world. There's not a lot of good data from the developing world. And it's divided into three subtypes. The first one is granulomatosis infantile septica. This is likely early transplacental spread, prolonged intrauterine infection. And these poor babies come out with a miliary-like pathology, very high mortality. The majority are in fact stillborn or die very soon after birth. They often have this characteristic pustular rash, and doesn't show well in the picture, but it looks almost like miliary TB, these small microabscesses within multiple of their organs. Early onset versus late onset disease, common variants of neonatal listeriosis. So it's related to timing of maternal infection and or neonatal exposure, whether it's in utero versus delivery. So early onset disease in neonate is considered less than 2 weeks post-delivery. These neonates will present with conventional neonatal sepsis type syndromes. It's often non-specific, lassitude, bulging fontanelles, fever, poor feeding, etc., cachypnea. It's associated quite strongly with prematurity, likely because the infection has been there, induces delivery or abortion of the pregnancy itself. Listeria often can be isolated from blood, amniotic fluid, meconium, and CSF on the baby. But the highest concentration is found to be in the lung and gastrointestinal tract, which suggests in utero infection is the mechanism of infection. Similar to many other neonatal infections like GBS, like your strep agalactium presentation, but they can occasionally have a pustular rash. Late onset disease, this is considered more than 2 weeks post-delivery. These babies are more often full term, and there it's thought that it's likely acquisition during delivery from maternal colonization. As we said, these mothers can have had a transient infection, they clear their bacteremia but remain colonized with the organism within the vaginal tracts and within the gastrointestinal tracts, and via that there's exposure of the neonate. And it's similar to other forms of neonatal meningitis, again, group B strep and E. coli, for example. Other sites of infection, so again, focal invasive infections via hematogenous spread, it can go anywhere: endocarditis, endovascular infections, septic arthritis, osteomyelitis, peritonitis, pneumonia, can form small cutaneous abscesses. In the setting of a patient who's bacteremic, pretty much everywhere has been described. But for interest, there's also traumatic inoculation causing cutaneous disease. Again, this is probably the more common form of true zoonotic transmission, besides consumption of raw milk, I suppose. And it's seen in vets, abattoir workers, dairy farmers. Can rarely be associated with an environmental injury. As we mentioned, Listeria can exist within the environment outside of a host. It's generally self-limited, so probably missed, but can in an immunocompromised host lead to disseminated infection. And just a word on endocarditis, according to literature, can complicate up to 5% of patients with the bacteremia in those who have risk for invasive disease. So it's prolonged bacteremia or persistent bacteremia. Patients who would not otherwise clear the bacteremia, like pregnancy, etc. It tends to affect those who are sort of at risk for verdant strep type endocarditis, so rheumatic hearts, patients with prosthetic valves. So that's the subtype. So a patient who has those together with host risk factors for listeriosis are at risk for endocarditis. And the majority are in fact culture positive, again, albeit that it's fairly rare. How do we talk about treatment? So the first thing to stress is that there's no randomized controlled trial, not a single one, on the treatment of listeria. So that leaves us with in vitro data, looking at plates, looking at broth culture, retrospective good opinion, and perhaps applying our minds to the pharmacological mechanisms. So start with what we do know. So the first thing is that these organisms are resistant to especially later generation cephalosporins, and it's to do with a unique penicillin binding protein type 3 that doesn't bind to your later generation cephalosporins, which tend to have a predilection for PBP 1, 2, or 4. It's almost uniformly susceptible, at least in vitro and in vivo, to ampicillin, gentamicin, which displays in vitro synergy with ampicillin and penicillin, and cotrimoxazole. In fact, there's intrinsic susceptibility to cotrimoxazole. It shouldn't be able to develop resistance to that. Thankfully, there's been no human cases of penicillin-resistant listeria. It has been found in the farming community within animals. So watch this space, unfortunately. It is usually susceptible in vitro, but has a variable clinical response of documented failures despite in vitro susceptibility to a number of other agents. These include fluoroquinolones, vancomycin, tetracyclines, rifampicin, and cefazolin. And if you look through the literature, there's a number of cases of patients who develop the infection while on the antibiotic or have in vitro susceptibility, again, based on all established microbiological criteria, but they fail therapy nonetheless. So the mainstay of therapy ends up being ampicillin or penicillin, or if one is penicillin allergic, cotrimoxazole is advocated. These drugs are the organism is reliably susceptible to them. They have a good clinical record of efficacy, at least looking backwards. They are fairly safe, and they have acceptable, again, ampicillin, probably less than Bactrim, but acceptable CNS penetrance for neurolisteriosis. This is from a paper from CMR earlier this year. In fact, it's a great review of Listeria. I'm just demonstrating the varying in vitro susceptibilities and possible synergy based on really a host of different studies. What's interesting is fosfomycin, again, not a drug we really like using for bacteremia and not something we would use at this point, but there's evolving evidence that fosfomycin actually demonstrates in vivo synergy, even though it is almost invariably resistant on the plate. And again, just solidifying that what happens in the microbiological lab is not always what's going to happen within our patient. And so space to watch, there's evolving research on that. What about what we don't know? Well, let's start with gentamicin. Historically advocated for synergy, so does combination therapy improve outcomes? And the other question is cotrimoxazole, is it equivalent to or better than ampicillin? So we'll go through these in a little bit of detail. So firstly, from a pharmacological perspective, gentamicin we know does not cross the blood-brain barrier, at least in adults. We know in neonates it does. It has poor activity against intracellular organisms. In fact, it's used to study intracellular organisms, essentially by exposing the culture to cellular cell culture to gentamicin, which will eradicate all the extracellular organisms, allowing only the intracellular processes to then be studied. So we know it tends to have very poor activity against intracellular organisms, and we know Listeria is predominantly an intracellular organism. Aminoglycosides are taken up via cellular penocytosis, and they have variable intracellular concentrations. So even if they do get into the cell, it's variable how much. And then they tend to remain within the lysosome, and their functionality is diminished. They tend to be inactive at the low pH that exists within the lysosome. So there's a number of at least basic scientific principles that would suggest gentamicin might not work. What about clinical data? So again, it's a quagmire of research. There are a number of retrospective cohorts and studies looking at this question in particular. So this one's from 2015. It was 100 patients with neurolisteriosis, so this is exclusively CNS disease, and there was no mortality benefit. This was another study published in 2010. Again, it was around 278 patients. And here, the patients who were treated with gentamicin, in fact, had a higher mortality. And this lastly was 102 cases treated in Spain. This study was any form of listeriosis, such as bacteremia or neurolisteriosis. And again, no difference if you look at statistical significance, although there was a tendency or trend towards an increase in early mortality, that p-value edging ever so close to 0.09. So essentially, based on these studies, the jury's not out. There may be harm in fact. And then we come to the biggest study, the biggest cohort study at least. So again, this was a prospective cohort that just looked at patients who developed Listeria in real time, 818 cases, it's the largest published cohort. And here they reported that those receiving an aminoglycoside had an increased survival, and anyone who had received, again, they were using amoxicillin instead of ampicillin with an aminoglycoside as combination for more than 3 days, it had an independently protective effect when it was added to the multivariable model. So again, the jury's not really out, and I'm not sure if it ever will be in the absence of a randomized controlled trial, but certainly there's concern for both harm and benefit, and it leaves a lot to personal and clinical judgment. I'll come to what most guidelines recommend. The next question was cotrimoxazole. So is it equivalent to or better than penicillin? So again, the same cohort, cotrimoxazole showed a tendency to, it was associated with better 3-month mortality as compared to many other parameters alongside aminoglycoside therapy. So this is not necessarily synergistically, but in isolation. But obviously in this study, at the very least, active beta-lactam therapy, which was usually penicillin or ampicillin, certainly showed the best mortality in terms of these numbers. There's an old paper, again, there's no randomized controlled trial, but there's an old paper looking exclusively at combination of an aminopenicillin or amoxicillin with cotrimoxazole, asking, is it the most appropriate regimen for Listeria meningitis? Again, it was a series of 22 cases in a single center over quite a long period. I don't remember the exact period. It was a single center study. Again, number of 22, so really nothing massive, but actually showed a statistically significant reduction despite the small numbers if you looked at mortality within the amoxil gentamicin or ampi-gentamicin group versus the ampi-bactrim group. So these were patients who were given it for synergy in a sense, and certainly this very small study retrospectively showed a decreased mortality, which despite the small numbers was significant. So this all sort of suggests that Bactrim is a reliable agent and certainly a fair alternative in the absence of being able to use penicillin, for example, in the setting of penicillin allergy. And then again, we know it gets into the CSF. And again, small studies and larger retrospective studies have shown its efficacy. So what are the guidelines say for invasive disease? So the South African guideline, which is now 10 years ago, suggests ampi and genta up front and confirmed Listeria meningitis. So this is specific to meningitis. Bactrim monotherapy in patients who have a penicillin allergy, and the duration suggested 21 days. All the guidelines suggest there's no trials here, so again, it's somewhat of expert opinion, the duration. Then the NICD put out a guideline in 2017 in the setting of the outbreak. And this was to actually essentially update the South African guideline. And here they suggested, again, ampicillin plus minus gentamicin. I will say that if you read the small text, the sort of undertone is one of probably not. So ampicillin monotherapy plus minus gentamicin left to physician discretion, with cautions in the elderly and patients on other nephrotoxins, or obviously patients with established renal disease. They do suggest using TDS dosing for gentamicin, and the suggested dose is 3 milligrams per kg per day, divided doses. Bactrim monotherapy, again, as per the original guideline in those with allergies, and again, 21 days. It's interesting, the estimate guideline, which is the most recent, there's an IDSA one that's quite old, 2004. The estimate one from 2016, at least in the table, doesn't mention gentamicin. It goes straight to ampicillin as monotherapy or Bactrim monotherapy and penicillin allergies. If you read through the document itself, again, it makes similar suggestions that one can consider gentamicin, but clinical equipoise is needed, and we don't really know where we stand. Who should one treat empirically in suspected meningitis? So again, the South African meningitis guidelines suggest all patients over 50 years old with suspected meningitis, immunocompromised because of immunocompromising or suppressive drugs, patients with alcoholism, liver cirrhosis, asplenia, end-stage renal disease, and diabetes. Interestingly, the South African meningitis guideline actively excludes HIV as a risk factor, although this, I think this was borne out after the outbreak. Data suggests that HIV-positive patients do have an higher incidence of developing invasive forms of disease. Interestingly, most guidelines I looked through do not mention HIV explicitly. Many of them are quite vague and just mention patients with immunocompromising conditions without really going into more detail. But again, these patients had disproportionate illness in the South African outbreak. All right, what about female gastroenteritis? So again, this is normally missed. But the question is, should one treat it? If you do find it, again, based on purely on expert opinion, most would suggest in those at risk, oral amoxil or Bactrim for 7 days. And suspected maternal infections, and this is in a patient whose febrile post is suspected exposures, either in the setting of a small or large outbreak or a patient who recently ate some of the suspect foods and then presents with an unexplained fever. There's a number of obstetric guidelines, but they'll work on the presence of the fever. You should blood culture them if they do develop a fever and start treatment, and then obtain placental culture at the point of delivery. In the absence of a fever, most obstetric guidelines actually do not suggest actively treating these patients, even if they have mild diarrhea or the like, probably suspecting that the majority of these patients never developed a true bacteremia and the risk to fetus was small. We can't talk about Listeria without very briefly talking about outbreaks. This image was so large, it has to be split across 2 slides. I've split it north and south hemispheres. So again, this is from a review paper looking at outbreaks from 1969 through to 2022, described by year, location, number of patients, serotype, and source of infection. I put it here predominantly to demonstrate, number one, there have been a fortune of outbreaks, and that's allowed us to study this organism. Number two, some of the interesting foods. If you look, for example, Nova Scotia, coleslaw was the candidate. If you look in Ontario in 2015, it was chocolate milk, which was in fact pasteurized, but it subsequently in post-processing become contaminated. So really anything, that's the point to demonstrate. And again, in the Southern Hemisphere, you see us, the biggest outbreak, 1,024 patients according to this paper. But some of the interesting ones, again in Ohio, there was an outbreak associated with cantaloupe, which is essentially sponspec or melon. And again, you'll see the suggestions of how to prevent listeriosis. One of them is, in fact, to make sure you wash the outside of these. It was on the outside, it was contamination from the ground, most likely. There was a number of infections, 147 in this outbreak. The South African outbreak, again, I'm not going to go through in detail, but just to demonstrate that, again, this shows you the rise and fall, thankfully, of the outbreak after it was discovered. This is from the NEGM paper from Thomas et al. And the interesting thing was that it was serotype 6. As you recall, that's certainly not one of the most common causes of invasive listeriosis at all. In fact, it was a minority. And that's one of the things that triggered the question, is this an outbreak? We're suddenly seeing a lot of serotype 6 when we shouldn't be. The characteristics in our infection, again, comorbid conditions, HIV, diabetes, and malignancy coming to the fore. Now, one could say that if you've got maternal infections in our background rate of HIV, could skew this a little bit. But again, disproportionate representation in those with, this is patients with invasive disease. So 42% HIV is higher than our seroprevalence. And there was no direct HIV positive to negative comparison in terms of outcomes that I could find on the study, even in the supplementary material, but certainly disproportionate representation of HIV. Renal failure, other immunocompromising conditions, alcoholism, and liver failure or liver disease, as mentioned, common. In our cohort, if you look at the over 50, it's around 200, it's around 160 patients. The majority of our patients also were in the younger cohort, less than 50. Even if you were to put 50 plus and 65 plus together, we have the majority in the 15 to 49. Again, a fair proportion of those were maternal cases, but certainly, again, maybe pointed towards our HIV seroprevalence contributing towards this, our outbreak in the numbers. The majority of patients were bacteremic, fewer with meningitis, and unfortunately, fairly high mortality, 27% in terms of those with known outcome. How does one prevent Listeria? Again, common sense, so washing and handling food, but this comes towards large-scale food production. And again, in our own houses, rinsing raw produce thoroughly before eating, cutting it and cooking it, before peeling it, scrubbing produce like melons and cucumbers, which just washing it with all the little divots and things within it, you may not actually be able to clear them, which is quite intense. Scrub each of your cucumbers before you eat them. Dry produce, keeping kitchens, washing not using the same knife or utensils once you've dealt with a certain foodstuff that may be at risk, cooking all meat and poultry thoroughly, and obviously choosing safer foods. In terms of recommended prevention for those at higher risk, especially pregnancy and or other immunosuppressive conditions, again, there's a long list. This is straight out of Mandel, but the list just gets bigger and bigger. Again, the more outbreaks we see historically. And again, melons making their way into this list, raw sprouts, in addition to the conventional deli meats, delicacies and meats, soft cheeses and seafood. In terms of prevention at a large scale, there's this hazard analysis critical control points concept, which is essentially supposed to be a system designed to prevent food safety issues, avoiding the problems before they occur. And all large-scale food production should go through this by conducting the hazard analysis, looking at the control points, setting the limits within those control points, defining how they're going to actually do surveillance and monitoring, implementing correction, verifying that they're succeeding when they implement correction, and good record keeping. So this is the ideal. And this is set up in the WHO, the FDA, they all have documents on this. There's multiple guidelines regarding appropriate food safety specific to listeriosis beyond the coverage of this talk. Implementation, though, requires input functionality from all the stakeholders and a good legal framework. And I tried to go into this in detail, but got stuck in the quagmire, so I abandoned it. But just briefly looking at South African legislation prior to our outbreak, it was somewhat deficient. These principles were not compulsory in meat processing plants, and that's from an act within the legislation. They didn't establish any, there were no compulsory minimum concentrations of Listeria within meat foodstuffs at all. You could have, for some organisms, there's set limits in terms of colony forming units. For Listeria, there's actually no minimum, or no maximum, so to speak. So Listeria was not considered an issue in meatstuffs. It wasn't a notifiable condition up until the outbreak. And then obviously during the course of the outbreak, there was a lot of difficulty compelling industry to comply with the investigation, again, representing the lack of legislation from a legal framework. If you look at the USA framework, any concentration of Listeria in any product will lead to a full recall. There's legislation leading to that and essentially shut down of production until the investigation is done. So again, there are preventative measures on the large scale that can be done. And perhaps this is what will speak the loudest. So there's obviously the massive Listeria class action, which is still ongoing by Spoor attorneys and co. If you look through, they update periodically where they are in the class action. They're still unfortunately in the infancy stages of actually moving towards court. Last two slides, just some interesting future directions for Listeria. So the first thing is, will we ever be able to vaccinate against this organism? One could ask the question if it's needed, given that it's a fairly rare infection, but perhaps in high-risk patients, like patients with pregnancy. So there's no current registered vaccine against Listeria. And again, similar to many organisms that are dependent on cell-mediated immunity, it's difficult to design a vaccine. The presence of antibodies is not protective at all. There is ongoing research. There were 2 papers in the last 4 years or 2 candidate vaccines. The one was still within a completely, both of them are still in infancy, but the first one would be using a hypervirulent strain of Listeria, using the organism itself, but removing many of the virulence genes, which will allow induction of overcellular immunity, which was protective in a mouse model, although serotype specific. And then using mRNA vaccines, which we know have a role, again, we've seen through COVID. And there's a paper from last year looking at that. And again, it may have utility in pregnancy, but if your aim is to stimulate a robust cellular immune response to be protective, then in patients with impaired cellular response, this may work. The last thing is in cancer immunotherapy, and this, again, there's been an absolute explosion of research using Listeria as a vector for cancer immunotherapy. Again, I think that there was something like 40 trials in progress, phase 1 and 2. Immunotherapy is really buzzword with a lot of knowledge at the moment. And Listeria as an organism that has this intracellular candidate for this. So that they essentially make these fusion genes within an avirulent strain. And once it's in the cytosol, the Listeria secretes these tumor-associated antigens, which are then expressed from the cellular immunity perspective. And it induces a specific tumor antigen-associated CD8 cytotoxic T-cell lymphocytes to target those tumor cells to which they've now been exposed. And eventually your immune system will attack the tumor cells. So again, really fascinating, and there's a lot of research in this field ongoing at the moment. And that brings us to a close. So thank you very much. I hope you found it interesting.
Thanks, Lior. That's really, really outstanding, and lots of good comments have come away from various people who've been listening. Really great overview of this. Just a couple of things I know we kind of just a little bit over, but just wanted to cover in a minute. Just reiterate your point about not missing neurolisteriosis. And most countries would include certainly advanced HIV in the list of categories where you should be empirically adding ampicillin. And I do think we can make a claim with that, especially as you say we've got local data to suggest that at least for invasive disease, whether or not neurolisteriosis, but HIV appears a risk factor. It's been shown in other studies as well. Certainly not to forget. And then the issue which you rightly said about the cells, it's kind of known as one of those that can cause a monocytosis and sort of a lymphocyte predominant meningitis, which is certainly true. But people misinterpret that. Exactly as you suggested, 2/3 of them are polymorph predominant. So we sometimes get pushback. We say, if you consider Listeria from this case, and it was, predominantly polys, and that's not at all enough to rule it out. In fact, most of them are. As you rightly said, the sort of median is 65, which is 2/3 of them being polymorphs. Okay, I guess there's one question which I always have, which I'm never sure of the answer to, about why pregnant women, although their risk of listeriosis in general, don't seem to get neurolisteriosis. It's really not a risk factor for meningitis or encephalitis at all. I don't know, does anyone, did you come across any reason for that in the literature? I'm not aware of any. It's a bit of a mystery to me.
I don't think it's clear. I think that it's, we talk about pregnancy, especially advanced pregnancy, as having some degree of deficiency in their cellular immunity, but it's not absolute. It's not like you're seeing PCP and fungal sepsis in patients with pregnancy. So I think it's like an attenuated, again, my assumption would be it's an attenuated sort of impaired cellular immunity. But I didn't come across any clear explanation for it. What was clear is that, again, looking at the Mona Lisa trial, there was no mortality and there was no meningitis. Again, in our setting there were, but again, in the setting of secondary risk factors like HIV, for example.
They certainly get a lot of bacteremias potentially, but as you said, not the meningitis or the encephalitis. And then John Freen on the call, who's dealt with this, but mentioned that there's an interesting historical perspective to Listeria from a South African perspective. John, do you want to mention that?
Yes. So this was a subject of an editorial in the SAJID in 2018, about the middle of the, when there was a lot of interest in listeriosis, about the middle of the outbreak in South Africa. But it was also at the time of the plague outbreak in
I don't know if I've fallen off or if John's fallen off. Jeremy?
Yeah, no, it's not just you. John, we're missing you at the moment. I think the great problem of going past 4 o'clock is that load shedding kicks in. Let's give John a second to join, and we'll see if we can re-get him again. Oh, yeah, he's dropped off a second. So let's just give him a second to see if he'll rejoin. I thought, your discussion certainly for the gentamicin and that is excellent. I remember that debate when the NICD guidelines were coming out about the gentamicin, and I think exactly as you said, I think we have one big observational trial which suggested benefit, multiple observational trials which suggest the opposite, and no randomized trials. And you forever in the potentially, despite as much effort as possible to get those. Let me just, sorry, I'm going to keep checking if John returns. So, yeah, to just double check if, sorry, just check whatever the reason for giving in a non-randomized way gentamicin, that there's a high potential for confounding by variability. By indication. Sorry, I'm multitasking. So in other words, there's a reason that, because it's not randomized, there's a reason some people got gentamicin, some people didn't. Presumably, one reason not to give gentamicin would include things like bad renal failure. And so that may be associated with death, obviously, the bad renal failure. So then it makes it look like gentamicin, giving gentamicin improved things, when of course it may just be that the patients who didn't get gentamicin were in some way sicker or in other ways. So yeah, it's a bit of a nightmare. I'm pleased to see that most of the recent guidelines have ditched it completely. I'm not a big fan, to be honest, as you can probably hear. I don't think the evidence is strong, and the risk of harm is enormously high, because minor glycosides are awful drugs to give unless you need them.